How do you treat urinary tract infections? As an internal medicine doctor, this is one of the most common conditions that we treat, so having a solid understanding of how to treat it is very important. So I'm going to show you my approach to treating this, and then also make sure you stick around to the end where I'll give you a lot of little tips and pearls that I've learned over the years that you might not have known about and may be useful for you. So for treatment of urinary tract infection, one of the biggest things that we have to do right from the get-go is determine, is this simple cystitis or is this a complicated UTI? So simple cystitis versus complicated UTI, of which one of the subtypes is pyelonephritis, so infection of the kidney. So what is the main difference between simple cystitis and a complicated UTI? So I'm going to draw a primitive little bladder right here, and then you're going to have your ureters going up and then going to your kidneys. So when you have simple cystitis, that's telling you that the infection is localized to the bladder and it's not really extending past this area. And so some of the symptoms that you're going to have in this case are going to be dysuria, so pain with urination, or urinary burning, or increased frequency and urgency. You may also get tenderness over the bladder itself when you press on a patient's abdomen, so you may also see suprapubic tenderness. When you have a complicated UTI, this is when there are signs that the infection has spread past the bladder. So it starts going up the ureters, and then starts going around the kidney, and you may start to see inflammation around the kidney. And you'll also just start to see a lot more systemic signs as well. So in addition to the symptoms on the left here, for complicated UTI, you're gonna have things like fever and chills. You'll have CVA tenderness. So when you kind of pound on the patient's back, it's going to cause some pain because of the inflammation around the kidney. And in general, you may see flank pain, which would, again, suggest that it's extending past the bladder. In terms of the treatment for both these conditions, I kind of like to separate it into two categories. So you'll have kind of what you'll do on the inpatient side of things, and then you'll also have what you'll do on the outpatient side of things. And so typically when a patient is admitted to the hospital, we're going to give them IV antibiotics. And so for both of these, your primary one that you're going to be reaching for is going to be ceftriaxone. And the dosing for this is 1 gram every 24 hours. But if the patient is bacteremic, that's when you would increase the dosage to 2 grams every 24 hours instead. A lot of times when people come in with complicated UTIs, though, we do tend to treat them a little bit more broadly, especially if they're getting admitted to the hospital. They're usually pretty sick. So when you look at the guidelines and recommendations, if anybody has a risk factor for Pseudomonas, then they should be getting IV cefepime or some other kind of anti-Pseudomonal, 1 to 2 grams every 12 hours. If they have a risk factor for multi-drug resistant organisms, then we will need to broaden them to usually Zosyn or piperacillin tazobactam, or to a carbapenem agent like meropenem. And then finally, if the patient is critically ill, then they recommend adding on vancomycin and then also getting abdominal imaging. In practice, I typically see that most people with complicated UTIs just kind of get upfront cefepime coverage early on because what are some of the risk factors for Pseudomonas? So really it's like any recent antibiotic usage in the last 3 months, any inpatient stay at a hospital or a nursing home, travel to places with high levels of drug resistance, or any recent history of a urine culture with some drug resistant organisms on there. When the patient is starting to get a little bit closer towards discharge, then we're going to narrow them to oral medications. And usually this is going to be based off of their susceptibilities on their urine culture. And so narrow to oral antibiotics based on urine culture results. And for the outpatient regimens, we kind of have a bit of a mix of what kind of antibiotics you can give. So for outpatient, say you just had somebody coming into clinic, then there's a couple of first line recommendations that you could give them. So the first line would be nitrofurantoin for 5 days, Bactrim or trimethoprim sulfamethoxazole for 3 days. And then you also have fosfomycin, which would be given for 1 dose. Nitrofurantoin is definitely one of the most common ones you're going to reach for. It's a really effective antibiotic. There are some things that you should be aware about. So sometimes we're a little bit cautious in really frail elderly patients, particularly in patients with GFR less than 30, it should be avoided. There's also something that the boards really likes to test on, and that's that nitrofurantoin can cause a pulmonary fibrosis kind of picture over long-term use. And so that's just something interesting to know. Bactrim or trimethoprim sulfamethoxazole sulfamethoxazole is also very great, but definitely be worried in patients, again, with an AKI. And also, it does have increasing rates of resistance. And so that's one reason you might not reach for it first line. And then fosfomycin, I see that very rarely used. Usually the ID doctors might reach for that when you're seeing more of like a drug-resistant organism picture. So those are the first-line medications that you can do, but you've also got second-line medications in case that the patient cannot tolerate them for some reason. So the first kind of set of medications would be beta-lactams, and these would be given for 5 to 7 days. So this would be things like cefpodoxime, augmentin, cephalexin, or Keflex. Now, Keflex is one of the most commonly prescribed antibiotics for this, but I actually tend not to favor it because it's 4 times a day dosing, which is really difficult for patients to stay adherent to. And finally, your last option would be a fluoroquinolone for 3 days. And so very strong option, but again, we don't really want to reach for it first line because of the risk of side effects like QT prolongation, tendinopathy, and also we don't want to get more resistance to fluoroquinolones either. So it's kind of a last line that you would only rely in kind of specific scenarios. What you'll see for the outpatient regimens for a complicated UTI is a fluoroquinolone for 5 to 7 days. Now, one thing I didn't mention before this is that the 2 fluoroquinolones that you're really going to be looking at are going to be levofloxacin and ciprofloxacin. Those are both the versions of fluoroquinolones that have adequate penetration into the urinary system, whereas you would not want to use moxifloxacin, which is known as more of the respiratory fluoroquinolone, and does not have very good penetration into the urinary tract. If there's high rates of fluoroquinolone resistance, greater than 10%, they recommend giving 1 dose of IV ceftriaxone, followed by a beta-lactam for 7 to 10 days, or trimethoprim sulfamethoxazole for 7 to 10 days. Or you could still do a fluoroquinolone for 5 to 7 days. And if there's a high risk for multi-drug resistant organisms, then you could give 1 dose of IV ertapenem and then give them fluoroquinolones for another 5 to 7 days. I would say definitely the most common scenarios you're going to run into are this one right here, where you're seeing that outpatient clinic visit and they've been having some suprapubic pain and dysuria for a few days, and you give them one of these 3 medications. Or they have some pyelonephritis in the outpatient clinic and you give a fluoroquinolone for 5 to 7 days. And then definitely the biggest one that you're going to see as internal medicine is, kind of giving IV antibiotics in the hospital, and then you get the urine culture result back, and then you narrow them to one of these medications, for 7 to 10 total days of therapy, or 5 to 7 if you're using a fluoroquinolone. Now let's move on to making the diagnosis of a urinary tract infection. And the key thing that we're going to be relying on here is the urinalysis, of course. And there are a couple of key things you want to be looking out for on the urinalysis. So obviously, you've got the nitrites, the leukocyte esterase, you got your white blood cells and bacteria, and you've also got squamous epithelial cells. So these are all things I want you to pay attention to. So nitrites, what are those? These are actually substances that are released by bacteria, specifically gram-negative bacteria from the Enterobacteriaceae family. One of the scenarios where you may have a nitrite-negative UTI is if somebody is coming in with a gram-positive infection like Enterococcus. So that's something to keep in mind. Leukocyte esterase is an enzyme released by white blood cells. So it's just another sign of infection. Bacteria obviously is going to help increase your suspicion for a true infection. And so generally you're looking for a colony forming unit count greater than 100,000 or greater than 1,000 if a patient has a catheter-associated UTI. Those thresholds are important thresholds to know for our official cutoffs for determining if somebody has a true UTI or not. Now, on your urinalysis, it's really just going to say many bacteria and moderate bacteria. So you're not really going to know until the urine culture how many colony-forming units there are. And then white blood cells, obviously, if there's more white blood cells in the area, then it's suggesting more inflammation. And this is what we call pyuria. And then squamous epithelial cells, If you see a lot of these on your sample, this is actually suggesting contamination, because these patients, ideally, they provide a clean catch sample. So essentially they start peeing and then they try and get a midstream sample so that there's not like skin flora that's contaminating the sample. But a lot of squamous epithelial cells, if it's there, it's probably a lot of like skin flora that contaminated the sample. And so if you see those, a lot of people will call that a dirty urinalysis, meaning that it wasn't very accurate. So if you see a lot of bacteria and some white blood cells, and then you see a bunch of squamous epithelial cells, then you're like, okay, maybe we need to get another urinalysis to really see if this is a true infection or not. Whereas on the other hand, if you see like no squamous epithelial cells, that gives you a higher degree of confidence in the accuracy of your urinalysis. Now, do be careful, because sometimes when people are talking about dirty urinalysis, they're basically referring to a positive urinalysis with nitrites and leukocyte esterase and many bacteria, rather than talking about the presence of squamous epithelial cells and whether it's contaminated or not. So in my personal practice, I try to avoid using the term dirty UA for basically all my patients, because people use it a little bit differently and can be kind of confusing. All right, so now I want to just move on to some common things that might come up, unique scenarios, and helpful little pearls that may be useful for you. So one of the common scenarios you'll run into is catheter-associated UTIs in patients with chronic Foley's. Remember that colonization is very common in these patients. They have asymptomatic bacteriuria. You don't need to treat it. Remember that there's that lower threshold for diagnosing a catheter-associated UTI with just 1,000 colony-forming units. And also, when you're collecting a sample, you're going to need to remove that catheter and then replace a new catheter in order to get a clean sample. Sometimes you'll see patients growing candida in their urine, and the question is whether this needs to be treated or not. And the answer is actually that it does not need to be treated. A lot of times you're going to see this in patients with chronic catheters. The only scenarios are if you really believe that they're having UTI symptoms from a candida infection, or if they're extremely neutropenic or immunocompromised. That's another special population is patients with a renal transplant. So these patients are on immunosuppression. And so let's say they come in with a UTI, how should this be managed differently? And one of the big things that we do here is that all patients with a history of a renal transplant should be treated with broad spectrum antibiotics like Zosyn or meropenem. And the treatment duration is actually extended from, this 5 to 7 or 7 to 10 days up to 14 to 21 days instead. This is because obviously it's already a kind of a vulnerable organ that's there, and if there's any extension of the infection that was inadequately treated, you may eventually lose the graft or the kidney transplant. Your attendings may ask you what the most common organism is for UTIs. So what is the most common organisms? And the answer is going to be definitely by far and away is going to be E. coli. And then after that, it's going to be a lot of those Enterobacteriaceae like Klebsiella and Serratia. And then you get a smattering of other things like Pseudomonas and Enterococcus and stuff like that. But definitely E. coli number 1 for sure. And maybe Klebsiella number 2. This is a very common question that most people know already, but what if somebody has bacteria found in their urine, but they don't have any symptoms of cystitis or complicated UTI? Then we call that asymptomatic bacteriuria. Now, there are 2 conditions that need treatment for this. So the 2 populations are going to be pregnant patients, or if they are about to undergo invasive urologic surgery in the near future. How about UTIs in men? So a couple of issues come up with this. So UTIs are definitely a lot less common in men because they have a much longer urethral tract. It's like a lot harder to get it contaminated and then for that bacteria to spread all the way up the urethra up into the bladder. So it's a lot less common. And so a couple of things that used to be practiced was that people would think that asymptomatic bacteriuria was not possible in men, so they would always treat it. And the second thing is that they would consider all UTIs in men complicated. However, neither of these are recommended anymore. So UTIs in men can have asymptomatic bacteriuria. It's not automatically considered complicated. And if they have persistent or recurrent UTIs, then you should really consider prostatitis as a possible diagnosis, which would need to be treated with a very prolonged course of fluoroquinolones or Bactrim. Sometimes patients will come in with a really, really severe pyelonephritis, and then all of a sudden the blood cultures that you got on admission are now growing gram-negative rods. So, oh shoot, they have a bacteremia now. What do we have to do? Well, actually, a lot of these people, they tend to do fine with just the standard normal duration of antibiotics. So it's actually recommended that you don't extend the antibiotic duration any further unless you have some strong reason to do so. So if somebody has bacteremia with a complicated UTI, you do not need to extend the duration of antibiotics. What if a patient comes in with Staph aureus in the urine? This is a very, very classic teaching moment for a lot of people, but Staph aureus should never be, part of the normal flora in your urine. And so whenever you see this, you should immediately think of possible Staph aureus bacteremia, which is then subsequently seeding the urinary tract. And so anybody that you see Staph aureus in the urine, you should order blood cultures and look for bacteremia. One thing that I ran into was, can nitrofurantoin be used for Enterococcus UTIs? Because to me, Enterococcus is kind of one of the scarier, organisms that can cause a UTI. And then nitrofurantoin is kind of this, we just give it to like people outpatient on the norm, right? Actually, it can effectively treat Enterococcus. However, and it's actually a pretty good treatment for it, but only if it's simple cystitis, because nitrofurantoin does not have good penetration into the kidney, only into the bladder. So only if simple cystitis. Another patient population that you may run into is patients with recurrent UTIs. And there were some board questions that I actually got wrong on this. So recurrent UTIs is defined by 3 episodes in a year, or 2 episodes in the past 6 months, or recent UTI treated with antibiotics in the last 3 months. So in these patients, even if they have simple cystitis, you automatically need to treat these people with a fluoroquinolone. You should also counsel patients on some lifestyle adjustments that they can make. So increased fluid intake, post-coital urination. So going to the bathroom to urinate after sex can sometimes help. If they're postmenopausal, vaginal estrogen sometimes is helpful. And then you can consider prophylaxis. So you can either do a post-coital prophylaxis. So if patients have clear onset of symptoms after having sex, then they can just take an antibiotic right after having sex and kind of prevent some of these UTIs. And then also some patients, if they just always get UTIs no matter what, they can just be on like permanent antibiotics all the time. But this is definitely a big risks and benefit discussion. So a lot of times the ID doctors will start getting involved in this case because there's a lot of side effects for having chronic antibiotics as well. What if you grow ESBL? Or extended spectrum beta-lactamase organisms, but it's susceptible to cefepime. Can you use cefepime in that scenario? The answer is no, you cannot use a cefepime because the beta-lactamases still can hydrolyze all the cephalosporins. And so you really need to broaden the coverage to include a carbapenem, like meropenem, for example. Next, let's talk about quadriplegic patients. I had a lot of patients who were I was the primary care doctor for, and they often get urinary tract infections because they all have chronic catheters in. And so this is very common for them. And a lot of times they don't have sensation below whatever their spinal cord injury was. So if they had it, pretty high up, they're not going to have any sensation from the chest down or, in their abdomen at all. And it's hard for them to tell if they have pain with urination or things like that. So in this case, what I've seen frequently is a lot of them can sort of tell that they're having a UTI because they often present with back spasms as their presenting finding. So definitely trust your quadriplegic patients who they know their body well and they know what symptoms are associated with UTI. And so have a higher suspicion for a possible UTI if they're saying they're having a lot of spasms recently. Next, we have patients with underlying urologic abnormalities like a kidney stone or any urinary strictures or stents placed or things like that. Typically in the past, and what I've seen in practice and probably what I've done as well, is treat all of these as complicated UTIs. But actually, these don't actually necessarily have to be treated as complicated UTIs. I think in practice, most people would still practice like this, but based on the research that I did and the recommendations, actually, these are not clear indications to treat everything as a complicated UTI. And then another thing that's very common is cloudy or smelly urine, because this is often something that patients will report to you. And although there is an association with reports of cloudy or smelly urine and bacteriuria on urinalysis, there's actually no clear evidence that treating patients just for the symptoms of cloudy and smelly urine has any benefits or improves outcomes at all. So they have to have one of those other cystitis or pyelonephritis or complicated UTI symptoms in addition to the cloudy and smelly urine before you really should treat it. So if it's only cloudy urine or smelly urine, there's a lot of things that can cause that. For example, diet changes or dehydration. So again, for isolated cloudy or smelly urine, no need to treat. And then finally, my last tip or pearl, which is probably one of the biggest discussions ever and is one of the most complicated things that you'll run into in the hospital all the time, is what should you do with a patient who has a UTI and is presenting with altered mental status, especially in the elderly population. So the Infectious Disease Society of America has been really trying to fight very hard against how aggressive we are in treating UTI with mild altered mental status in elderly patients, because there's a lot of evidence that we're over-treating these patients and that they did not really need treatment at all. And really, it should have been treated as asymptomatic bacteriuria instead. So there's a couple key points that they make. So first, they like to say that there's no evidence that UTIs in elderly are a cause of decreased functional performance, like increased falls or weakness or things like that. They recommend not ordering a urinalysis if there's an absence of any urinary symptoms. If there is a positive UA that was obtained on admission, for example, there is no need to treat immediately. And the reason for this is because they've done some studies and found that watchful waiting and trying to reverse other causes first was not associated with worsened outcomes in this patient population. So trying to reverse things that may be more reversible, for example, causes of delirium or medications that might be causing altered mental status. Trying to reverse all of those causes first before you start to jump immediately towards treating the UTI was not associated with worse outcomes. So treat other causes first. For example, meds, deliriogenic, factors, things like that. All right, and that's it for all of my tips and pearls for treating urinary tract infection, as well as, a general approach for how to treat urinary tract infection by differentiating between simple cystitis and complicated UTI. So again, I hope this was helpful for you guys. If you have any questions, please be sure to leave them down in the comments below, and I will definitely answer as many questions as I can. Really hope this helped. Thanks again for watching, and I'll see you in the next video. Peace.